The following is a presentation of Project Independence and WCWP. Project Independence is the Aging in Place initiative of the town of North Hempstead. We provide programs and services designed to assist and support the older town residents who wish to remain in their homes as they age. If we don't currently provide a service, we will try and connect you to that service. Call 311 or 869-6311 to get more information or receive services.
Welcome to Project Independence and You.
Good morning and welcome to Project Independence in You, Community Talk Radio on 88.1 FM and WCWP.org. I'm your host, Rebecca Miller, along with our co-host, Otto Los. How are you today, Otto?
Good morning, Rebecca. It's a nice day, and I'm feeling good, so I'm good.
It certainly is nice out today. Beautiful day. And also our radio show producer, Kristina Lew. And we'll be talking with Kristina later in the program in our Talk of the Town segment. But right now we have a really, really wonderful guest, and we're so appreciative for Dr. Murthy, who is the Vice Chairperson of Neurology at Northwell. And we are really happy to have you here today. We're going to be learning some facts about neuropathy, but just want to welcome you and say thank you for giving us your time. This topic comes up a lot in people's lives at some time. So, and it's a little confusing. So, I'm happy to have you here to kind of clear up some of the facts that we're looking to find out about.
Thank you. Thank you. Good morning to all. I'm ready as soon as you shoot your questions.
Okay. So, we can just start off by, what actually is neuropathy?
Very simple. The word neuro means nerves. Pathy is pathos, meaning sorry. In other words, any affliction of any part of the body is called pathy. So if you have cardiomyopathy, it means it's heart. If it is neuropathy, it means it is nerves. That's what simply it means. If you are asking about peripheral neuropathy, that simply means that the nerves in your arms and legs, sometimes face and trunk, can be affected by abnormal sensation or weakness. So in order to understand it, it's very simple. Nerves are like electrical wires. Mm-hmm. And electrical wires have insulation and wires inside the insulation. Human nerves are exactly the same. There's no difference. The only difference is one is mechanical device, another is a living device, and it conducts electricity. So imagine if your nerve is not healthy, it will alter the perception of sensation, which is fine touch, pinprick, cold, heat, vibration, and sense of position. That's a sensory nerve. If it is a motor nerve involvement, you will have weakness, tone will be altered, muscles may twitch, and it is predominantly in the upper and lower extremities. So there is a sensory system, and there is a motor system. The third system in peripheral nerves is called autonomic nervous system. Autonomous means you cannot control it. It's like heart rate, sweating, vasculature changes. That's not under your control. Those are autonomic nerves. And there are certain neuropathies that can also affect that portion of the human nervous system. So for the audiences, one must understand, we're not talking about the brain, spinal cord. We are talking about the nerves that either go to the spinal cord and brain, which is sensory system, or the motor system that comes from the spinal cord to the muscle. That's neuropathy.
Many years ago, I went to an exhibit, the Bodies exhibit, and I recall something, they had like bodies there, and they talked about that within the human body, there's like 1,000,000 miles of nerves. Is that an exaggeration or?
What is true?
Yeah. So when
I
I
won't
hear
say
that,
millions, nobody has measured the length appropriately,
so
but there are tons of them. Yes.
but when I hear that, I say to myself, how do you ever find out where there's damage to the nerves when there's so many places within the body that, it can be damaged?
No, it is easy.
Is it?
Remember I said nerves are like electrical wires?
Right.
Right.
Any part of your body that is afflicted with neuropathy by your history, talking to the patient, by examination, looking at the nervous system, muscles, nerves, and autonomic functions, and most importantly, which is my additional specialty, is testing the nerves with electronics. So it is very simple. You stimulate a nerve and record the response from the sensations. For example, if you have a simple disease called carpal tunnel syndrome, you stimulate the nerve in the hand, pick up the response from the muscle and the finger. And if there is a delay, which is depicted in the screen, that's the diagnosis. Very simple. And if it is not there, then you look elsewhere. And this all can be done. So your nerves in the face, nerves in the arms and legs, even nerves in your trunk can be stimulated and recorded. So while there are millions of miles of the nerves, when you test the human body and tailor your testing, including a good history and physical examination, you can figure it out which part of the body is affected and then tailor the study according to what is being exhibited by the patient. And most of the time, almost all the time, you can figure it out, whether it is the insulation or the copper wires. Insulation is myelin. So there are only two types of neuropathies: demyelinating, which means the sheath is broken, or the copper wires are broken, which is called axonal. So very simple scheme is either you have axonal neuropathy or demyelinating neuropathy or mixed. And your test tells you exactly what it is.
Some people, I'm sorry, but one of the common areas I hear, people wind up having it in their feet, neuropathy, and they get a tingling and a burning on the soles of their feet. Is that a fairly common symptom?
Yes, sir, it is very common. Remember that the commonest cause of neuropathy is axonal, the copper wires inside the nerve. It is called axon. And most of these neuropathies are what is known as length dependent, meaning the longest nerves are affected the most. So imagine your nerve from your back to the foot is the longest nerve. So when the neuropathy occurs, such as in diabetics, alcoholics, and many other diseases, the feet becomes numb first. And until the numbness reaches the mid-thigh, you won't get problems in the fingers. But if it ascends up to your thigh, then you will start getting tingling in the fingers. So commonest presentation of neuropathy, the common neuropathies, is numbness in the feet and tingling, with or without pain.
How would you go about like using that as a specific example? I walk into your place and I have this symptom. I have the feet problem. How would you go about trying to? I don't think you can fix neuropathy from what I hear, but maybe you could answer that question. I don't know.
Yeah, that was my question.
Yeah. How would you go about, like I walk in the door and I have this problem, which luckily I don't, but let's say I do. What would we do? What goes on?
It's very simple. When you walk through the doors, I will greet you with a smile.
That's good.
Make you comfortable. You'll put a gown on, and I will ask you questions, which is called history. And you're going to tell me, Doc, I have tingling, numbness in the feet. I'll ask you the duration. what kind of symptoms it is. Is it painful, not painful? Is it getting worse or not? So that's the part of the history. But most important part of the history is I'll go through your personal history. Are you alcoholic? Are you abusing drugs? I will also ask you if you have heart, lung, liver, kidney, diabetes, thyroid, HIV disease, all sorts of questions. That's the preliminary history. Then I'll examine you. I'll examine you from head to toe. And when I examine, I will emphasize the legs. So I'll test your sensation, and I have the whole toolbox, fine touch, pinprick, cold, vibration, and other things. And then I'll test your strength and reflexes. So if you have neuropathy, most likely you will tell me that your perception to touch or pin or cold is decreased in the feet. Your ankle reflex will be absent, most likely. And your muscles may not be weak if it is sensory. And that's how the initial evaluation is: history and physical examination. If I find that you are a diabetic, then buck stops there. I don't have to go and do exotic, time-consuming, money-consuming tests. I will simply tell you, sir, this is most likely a diabetic neuropathy, and here is your treatment. Good control of diabetes, take your vitamins, exercise. And if you say, doc, numbness bothers me, but I have little burning pain, which is typical, then I'll treat you with medications. The commonest medication we use is called gabapentin. And there are many other drugs. So I titrate your symptoms with your disease and advise you. Majority of the cases, you don't have to have exotic testing, which is costly, time-consuming, and unnecessary. But sometimes you tell me you have neuropathy and I don't find any cause. Remember, 46% of the patients who come for neuropathy, we never find a cause. We have finding of the cause in greater than 50%. And as the science advances, we are learning more and more. When I was in medical school, 75% of the patients, we didn't know why the hell the neuropathy occurs. Now, in the United States, in a major center as Northwell, we are almost reduced to 25, 30%. That's my personal data. So your neuropathy is to be tailored based on your symptoms, physical findings, any systemic illnesses, and I score all those things in details. It takes an hour to initially evaluate you, and then I'll proceed with what I need to do. Sometimes I end up doing exotic testing when I don't find the cause.
Well, I like that answer, to be honest with you, because that's an honest answer. You can't find the cause, so that's it. But I guess then at that point, what it is to manage the symptoms and how severe they might be.
Sure. If you exhaust your testing and establish that you have neuropathy, you keep following the patient carefully, and only when you have is treat them symptomatically. How do you treat symptomatically? Most neuropathy with pain can be treated very effectively these days with variety of medications. If you have weakness, physical therapy, and I personally teach my patients how to do the therapy. Avoid trauma to the foot because you don't heal if you have neuropathy. So foot care is very important. So symptomatic treatment and careful follow-up. Remember, initially you may not find a cause, but that does not rule out that there is a cause. There is always a cause somewhere. You're not finding doesn't mean that there is no cause. It means that we don't find a cause. But in those cases, the most important thing is follow the patient and keep watching what is happening and then reinvestigate. Because after all, our idea of treatment is cure besides symptomatic therapy.
Are there medications that can contribute to the symptoms of neuropathy? You know, like
Did
we
you
all
say-
take medication for a variety of reasons.
Can medications cause neuropathy? Is that your question?
Well, can it contribute to the neuropathy?
Oh,
Make it,
absolutely.
yeah, make it
Absolutely.
worse? Yeah.
Yes,
What kind of medications?
I will tell you. It's very simple.
Okay.
Toxins are alcohol, which should be avoided under any cost. Now, if you are suffering from, say, urinary tract infection, females come to the doctors with urinary tract infection and they are given medications and antibiotics. They can worsen neuropathy and they can even precipitate neuropathy. The doctors who give you tons of medication for heart ailments, abdominal ailments, they can all cause and contribute to the worsening of neuropathy. You know, the tragedy in this situation, remember diabetics? And the commonest drug these days they use is the drug called, I'm blocking it. And that is the commonest drug. And it controls diabetes. But it can also cause neuropathy.
Mm-hmm.
So the doctor has to be knowledgeable. And therefore, we ask you the list of all medications. For example, you have breast cancer. You are going to get chemotherapy. Now, it's a life-saving medication. But one of the causes of chemotherapy is neuropathy. People who have alcoholism, they get a drug called disulfiram. That itself can cause neuropathy. The drug I was forgetting was metformin, very common drug. And believe it or not, it can cause neuropathy. So just because you are a diabetic, it does not mean the worsening of your neuropathy is diabetes. Your diabetes is under excellent control, and yet you have worsening of your neuropathy. So I call the diabetologist or the internist and say, hey, find an alternative to metformin. So a doctor in this business of neuropathy has to be very much aware as to what's going on. That's personal history. And that's
Thank
very
you
important.
so much. Murthy, we just have to take a quick break. I don't mean to interrupt because this is really very, very eye-opening information for a lot of our listeners, I'm sure. You were listening to Dr. Murthy, who is the Vice Chairperson of Neurology at Northwell. We will be right back with Project Independence and You.
So I get this call from my grandma, and she's like,
"What's a podcast and how much does it cost?"
So I tell her, podcasts are like radio shows, but you can download them on any device and listen to them anywhere at any time, and they're free. And then she says,
"I see, but where can you find good ones?"
And I'm like, go to wcwp.org/podcast and check out the lineup of original shows, or download any podcast app on your phone or tablet and search for LIU Studios. And she's all like,
"Oh, that sounds easy."
and then she asked me what an app is.
LIU Studios podcasts, available on any podcast app. You know, those little button things on your phone screen. Just ask your grandkids.
And welcome back to Project Independence and You, Community Talk Radio on 88.1 FM and WCWP.org. We are speaking with Dr. Murthy, who is a chairperson of neurology at Northwell, and we are just learning a lot about neuropathy. And before the break, we were talking about medication and some of the causes, and there is a list of medications that apparently can cause neuropathy. So my question is, Doctor, do the medications actually cause neuropathy, or is it something that it kind of that exists in us and that triggers it? And is it, if it's caused by medication solely, is that reversible? And is neuropathy curable at any point?
Good question. Drugs can induce neuropathy whether your nerves are healthy or unhealthy.
Okay.
So if you are going for a chemotherapy and you are being given medications, that will cause neuropathy. Even though your nerves prior to the medication were completely normal, you had no symptoms. Now, if you already have diabetes or other causes that are potentially neuropathic causing disease disorders, it can make it worse. That's why many of the doctors who give medications for medical illnesses usually inquire and tell them, hey, if you have tingling numbness in the feet due to whatever reason, this drug can make it worse. But I will choose the chemotherapy to save my life. So it's a double-edged sword. Because neuropathy can be treated. And in most neuropathies induced by drugs, fortunately, are reversible.
Right.
Once the medication stops, take vitamins, exercise, and it gradually improves. It may improve to almost 100%. But if the nerve damage is so bad, then you have to live with it and treat symptomatically. For example, a very common drug called vincristine, extensively used in oncology, can cause neuropathy, muscle weakness, and many of the patients don't recover completely. My training at Sloan Kettering, when I was a young guy, taught me that, and I still see it. Now there are drugs for treatment of leprosy, Dapsone. Remember, leprosy is the commonest cause of neuropathy in the world, not in the United States. That can cause neuropathy. There are many drugs. So your question is, yes, all physicians must be aware, give informed consent to the patient, caution them, vitamin them properly, and then let it happen if it happens. And if it happens, treat it symptomatically, give hope to the patient that after the chemotherapy courses are completed, it might increase, and there's a good chance. But some of them don't improve.
Doctor, you mentioned before diabetes and the medication. So, if someone says diabetes, you said you could stop there, and now you know what's going on with the neuropathy. So, is it always the medication that diabetics have to take, or is it the actual disease? And are there other diseases that are cause neuropathy?
Diabetes causes neuropathy. Even when you are a pre-diabetic, when your hemoglobin A1C is less than 6.5, which defines whether you're a diabetic or a pre-diabetic, even the pre-diabetics get neuropathy. Very common problems. General doctors don't understand it, but I have tons of them. They're pre-diabetic, they come with burning pain, it is neuropathy. So diabetes causes neuropathy. It is the commonest cause in the developed countries. But other than chronic use of the medication metformin, which a neurologist with proper history can determine, commonly medications used for diabetes would not cause neuropathy.
In the notes that we received, there was talk about body fluids that can influence neuropathy. Is there a special battery of tests that people would take that are directly related to the idea of discovering what the situation is with neuropathy? Is there just a special battery of tests, really?
Well, your question is kind of vague for me, sir. I'm sorry. Body fluid is a general terminology. Can you specify what you mean by body fluids?
Well, I wish I could. I guess the question is, are there specific body fluids that should be checked for that would lead you to help find out about the neuropathy, to diagnose the neuropathy?
Well, I could be very specific. Yes. If you have a neuropathy, the only body fluid that the neurologists examine is spinal fluid. It's called lumbar puncture. You put a needle in the spine, drain the spinal fluid, and analyze it for immune proteins. You can also look for malignant cells. because they can wrap around the nerves inside the spinal canal and cause neuropathy. So mostly the immunological disorders can cause peripheral neuropathy. For example, the pandemic that we went through, COVID, that can cause immune-mediated neuropathy. Guillain-Barré syndrome causes immune-mediated neuropathy. Abnormal proteins in the spinal fluid can cause neuropathy. So that's the body fluid that we neurologists do it only when you suspect that this is an immunological or a malignant disorder. Otherwise, there is no need for doing a spinal tap.
So in terms of the reversibility of neuropathy, if someone, like you had mentioned, stop taking certain medications, they can exercise and get back on their feet, that it can resolve. With neuropathy that comes with disease, or anything else outside of medication, even if you have a trauma, you get neuropathy because of some kind of accident that you've had. I'm just curious as to when and if it's ever reversible, and or if it's just kind of treatable.
Both.
Okay.
Reversible in the sense that, remember, the best part of peripheral nerves is that it regenerates. Brain does not regenerate. You have X number of cells, you're fixed with it. So don't lose it. Peripheral nerves, remember, sometimes you see a TV where the plant roots are sprouting and going down. Similarly, a nerve has a great ability to repair. It sends those axons down 1 millimeter a day, and it reaches the sensory fibers, the sensory receptors, it reaches the muscles. And we have techniques of knowing. For example, if a person has trauma and he has damaged his sciatic nerve or median nerve, we make a diagnosis, repair the nerve, and then subsequently I follow them, and I have techniques where I can see if the nerve is regenerating by my machines. So yes, a reparative process is available to the nerves as long as you are nutritionally well, take your vitamins and exercise. But not all nerve injuries are repairable or recoverable. For example, if you cut your sciatic nerve accidentally, unless immediate surgery is done to reconnect the nerve, and we have excellent peripheral nerve surgeons. Their aim is to connect the nerve. The distal nerves are dying, but the nerve stump that is healthy, it sprouts through the tubes. It's beautiful.
Wow.
And it is growing very fast. So don't wait too long after a nerve injury. And that's the job of doctors like me, that we have to define when is the appropriate time for surgery. Within 6 months, it has to be done. If it is trauma and you are in the emergency room and you see the nerve is disconnected, there is no need to wait for 6 months. Connect it right there, and there is good recovery.
And you can actually see the nerves, what nerves have to be connected. And
oh, absolutely. Micro neurosurgery. They put a microscope and look at the nerves, the fascicles, they suture them, fascicle to fascicle, repair the nerve, and it takes time. Remember, it grows 1 millimeter a day. So if you have a sciatic nerve and your leg is 60 centimeters, it will take 2 years to grow. First the thigh, then the leg, and lastly the foot.
one of the symptoms that I read is muscle twitching. And I know people who've had a diagnosis of essential tremors. Could there be a mix-up on that, like where twitching could be said that it was essential tremors and maybe it's neuropathy that caused the twitching in the fingers?
It's an excellent question, sir. The tremor is usually not peripheral nerves. The tremors are usually central nervous system. Benign essential tremors. I have many patients and it has nothing to do with peripheral nerves. It
Okay.
is a central mechanism. Now, twitching is the very important question you asked. When people have muscle twitching, that means that your muscle getting the nerve from the cell in the spinal cord is damaged. That is what used to happen to poliomyelitis. Thank God to Salk and Sabin that we have vaccines. But these days, the common cause of a muscle twitching is Lou Gehrig's disease, ALS or motor neuron disease. I have many patients, and they present with fasciculations. That's a anti-horn cell and nerve degeneration. Now, there are other causes like muscular atrophy, which is hereditary. But the most important thing is there is also a phenomena called benign fasciculations. Benign means it's not bad. There are many patients, young adults, that come with muscle twitching. And the first thing they do is put the computer on, and what do they see the first thing? ALS, motor neuron disease, Lou Gehrig's disease, and they're half dead because they read the computers these days. They come to the doctor running. There is a way of deciding, is that a ALS fasciculation or it's a benign fasciculation? Lot of body aches and muscle twitching. And I have patients who have been visiting me for 22 years. There's a doctor who has muscle twitching, and he thinks that in 6 months he's going to die. And he keeps coming. And I told him, this is 22nd year. I must be talking to your ghost if you have been dead. So there are many people, and it is frightening. So the doctor's responsibility is carefully examine, do the electrophysiologic testing, and reassure them that this is benign fasciculation, give them some anxiety relieving drugs, and ask them to go about their life.
Well, Dr. Google can be good, but Dr. Google can be dangerous too.
Very dangerous.
Yeah.
You know, we all become doctors when we go to Dr. Google. You know, that's a fact.
It
I
is,
think.
I must say, it is good to be well informed, but take an expert opinion, not Google opinion.
Right. What I've heard people talk about nerve tests, like you described tests, and I've also heard people say that they're pretty painful. Is that a fact or a fiction?
It is both.
Okay.
First of all, you have to inform the patient what you're going to do. Tell them that there will be small electrical currents. Many patients who do the nerve test by electrical stimulation tolerate it very well, even kids. They make fuss, give them chocolate, they participate. It is the second part when we put needles in the muscles. So when a patient comes, I say to them, don't be afraid of the needles because they are not the needles that you get your blood drawn. I use very specialized needles. They are Teflon coated single fiber needles. They are usually painless. But to say it is absolutely painless is a myth. Some discomfort is there. Many patients come and say, I'm frightened with this test. They go smiling and say, Doc, I was misinformed. Yes, there is. What is pain? Pain is a threshold phenomena. Some people can tolerate, some people faint. So it is all relative. But over almost 900 to 1,000 patients I do the electrical testing, I did not have one patient who refused EMG testing. You have to reassure them. You have to be kind. You have to explain it to them. When they are informed, they're happy.
Yeah, I think I believe personally that the mind is a powerful tool, and if you approach the fact that yes, there's going to be some pain, it might not be as painful. I don't know.
Right.
I mean, luckily for me, I haven't had those tests. So
It's a relative phenomena.
yeah.
Yeah. Dr. Murthy, you had mentioned something, and I'm just curious about it because it's, it's timing and everything. COVID. So I actually have a friend who is in her 50s, young, pretty healthy, and she and I had COVID, both in the very beginning, very early on, I had very mild, and she had every other thing going on. And she wound up with neuropathy. So I'm just wondering if they know why COVID causes neuropathy and if that type is reversible, because I do think she still suffers with it today, though I don't think it's as bad as it was.
It is a very good question and a timely question.
Right.
Remember what COVID is. It's a virus.
Right.
And it causes surge of certain substances in the brain. And that causes memory, language, and behavioral problems. But what it also does, that it produces antibodies. Just like flu, just like many organisms, antibody production is protection of the body. But some antibodies mimic toxins which can affect the nerve. So yes, peripheral neuropathy is a very common manifestation of severe COVID. It is immune mediated and it is treatable and reversible. I have many patients since the epidemic of 2020 ongoing, and they have all sorts of neuropathy: facial nerve, brachial plexus, peripheral neuropathies, foot drops, Guillain-Barré syndrome, and they're all treatable. You catch it in time, you treat them with immunological proteins. So you want to kill a small dog, send a big dog. That is IVIG therapy. And that's what is treatment, and then symptomatic treatment. And many of my patients slowly recover because it is immune mediated and recovery takes place. Not 100%, but majority will improve.
Excellent. We actually have to take another quick break. Very just great information. We will be back with Dr. Murthy, who is the Chairperson of Neurology at Northwell. You're listening to Project Independence NU, Community Talk Radio on 88.1 FM and WCWP.org. We will be right back.
Take WCWP with you wherever you go with the WCWP app. Listen live 24/7 to all of our streams, all from one app. Plus, call the studios directly from the app and visit our social media. Download the app through the iOS App Store on Apple devices or the Google Play Store on Android by searching WCWP Radio, or visit WCWP.org for links. The WCWP app, available now on iOS and Android devices.
Welcome back to Project Independence NU, Community Talk Radio on 88.1 FM and WCWP.org. We've been speaking with Dr. Murthy, who is the Chairperson of Neurology at Northwell Health, learning all kinds of facts about neuropathy. So interesting. And I have to ask you, are you also a teacher?
Yes, ma'am. I'm the Director of Clinical Neurophysiology, Associate Professor, and my heavy duty work is teaching and training doctors in my EMG lab for neuropathy, muscle disease, nerve disease, Lou Gehrig's disease, and all sorts of things. But
You're
I
an
do
excellent teacher.
Oh,
Excellent
yes.
teacher.
Thank you.
I'm learning so much. I'm just kind of absorbing everything. I know, Otto, over break you had a
Yeah,
point
one of
you wanted to
the
bring up.
thoughts that struck me when you pointed out that a lot of people, not a lot, but a number of people, as a byproduct of COVID, ended up with neuropathy. And I think what that hit me with was it's important for us as patients to look back and say, hey, you know, I didn't have that problem before COVID, and be able to analyze all your own situations some and provide as much input as you can to the doctor who makes the diagnosis. I just, you know, it's an editorial comment where I believe the patient has a part to play in this whole thing, and they have to tell you what's going on.
I will respond to that. First of all, I'm Vice Chair, Rebecca, not Chairperson, Vice Chairperson.
Vice Chair. Yes.
I don't want to offend my chair. Now, Dr. Lew, you said something I overheard while it was a break. The most important part of a doctor is listening to the patient. There is nothing parallel to it. One of my teachers at Sloan Kettering at Cornell in 1973 told me that 86% of the time, if you listen to the patient carefully, you can make a diagnosis. And he's absolutely correct. So therefore, when a patient comes to me, we have to inquire, let him speak freely, but interject and ask, when did it become apparent? Did you ever have it before? So history taking is a fine art and must be exercised. Many a times patients come with a very poor history, but that's not patient's fault. They are not doctors. They don't know how to describe it. You have to elicit that. You have to be careful. That's why when I was telling you history, go through everything and then examine the patient. And that's very important statement you made, Otto, Mr. Lowe's.
Otto was fine.
I respect that enormously.
Yeah, I mean, I always tell people, don't be afraid of the doctor. Talk to the doctor. Tell them, the old school from my generation is a lot of them will just go to the doctor and they don't say anything. And, you might as well be a donkey and let the doctor treat you. Yeah.
I will respond to that.
Yeah.
I'm the only doctor in my department who goes and meets the patient in the waiting room, shakes hands, smiles, bring them to my examining room. It's actually part of the examination, how they walk, but they don't know that. But they feel that they are connected. How many doctors go to the waiting room and bring their patient into the examining room? You have to be patient. You have to be compassionate. You have to be friendly. Then they will express themselves, because you ask a lot of personal questions too and make them uncomfortable otherwise. But they understand you mean well.
This is great stuff, because I really believe that you have to have a relationship with your doctor where you can talk back and forth. And unfortunately, today in this world, a lot of doctors, and I respect the fact that they are really on the clock in some cases because of the way the medical structure is now compared to many years ago. A doctor cannot give you an hour of his time without being chastised himself, maybe. And I don't know that as a fact, but I'm just guessing that I think in some cases I've heard that can happen. That makes it more difficult, which means all the more why the patient has to be somewhat organized when they come in so they can get the best use of the doctor's time. If you have a minimal amount of time, if it takes an hour to get organized to where you're now getting down to something, the nitty gritty, you wasted a lot of time. And I think it works on both sides.
Very good statement. They allot us time, 20 minutes for follow-up, 40 minutes for consult. And I told them point blank, don't tie me with the time. A follow-up must be 30 minutes and a consult must be 60 minutes. I don't care. Otherwise, take me off the schedule.
Right.
How can you cut time with a guy who is sick?
Yeah.
I mean, you got to spend time to make him comfortable.
Right.
And that what you said was absolutely correct. Doctor's life has become very hard, but I have the luxury, being a senior guy, that I can dictate how much time I need.
Well, that's great. It's great to hear all this. I do have another question. I don't know if we covered this or not. I don't think so. Is there a genetic factor to neuropathy? And also, if there is, and I guess, and even if there's not, what are the things we can do to prevent neuropathy from happening?
Excellent, Rebecca, excellent. Yes. You know that everything that human body is all about is connected with genes. Mm-hmm. There are defective genes, and they can cause neuropathy. There is a whole list of genetic neuropathies, and you will hear the common word Charcot-Marie-Tooth disease. What happens is that a mother Our father sometimes can transmit that gene, and that gene is responsible to maintain. Remember the insulation and the wires of a nerve? They mainly affect the insulation and cause demyelinating neuropathy. And there are 10 types of those. And yes, the tragedy in those situations is that they begin usually in childhood. My boy walks clumsy, he's not participating into school activities. And then there is a tendency to ignore it. That is just a delayed child. By the age of 10 or 11, they start having flopping their foot. Then they come to the doctors. And very simple, take a good history. Family history becomes extremely important. And then you discover that the aunt had a child with the same thing, and mother started walking funny because the course is so variable. And that's the hint that this is a genetically inherited neuropathy. Very simple. Good family history, family tree analysis, do the nerve test, define what kind, and then do the genetic testing. Lo and behold, in majority of these patients, you will find it. So there are lots of neuropathies. For example, even your mitochondria, the energy unit of the body, there are mitochondrial diseases that can cause neuropathy. So yes, there are many genetic disorders. Unfortunately, not much is available to treat them. Some diseases are being treated, but majority of them don't have any treatment. But there is hope, because these days research is so rampant that they are finding things that can put extra protein in the nerve. For example, patients who have spinal muscular atrophy, who are atrophying all the muscles, there are new drugs. And infants who are paralyzed are getting those drugs, and they are now standing and walking. So yes,
Wow.
there are enormous research activities going on. And they are, of course, costly because it costs a lot of money, but it's worth it. And we have patients that they have been treated by our pediatric neurology, and never give up hope. There is treatment coming. Establish the diagnosis, follow it carefully, follow the literature, and treat the patient. I have adult forms, and I've been treating a couple of them. There is hope. There is some recovery.
You know, what's interesting is that what you're describing, that there's so many different kinds of neuropathy and whatnot, makes for a great marketing opportunity. If you go on the internet, there are about 300 magical things that you can use to take care of neuropathy. You know, I could name names. I know people have tried most of them, you know, and they all promise it's going to end your neuropathy problems. Are there an opinion as to what might be among the better ones from experience that you hear from patients, where you may have something that can be applied directly to the skin to kind of alleviate, or not maybe totally alleviate, but to minimize the pain and the symptoms that come from it?
Good question. There are a lot of quackery in the business. There are a lot of false hopes. And patients ask me, and I said, stay away from them. They're costly and no proven data. But your question is, the latter part of your question was, can we improve them with medication by ointments or patches? Yes. After all, pain can be controlled by creams, lidocaine cream, sometimes other creams, medicated creams, and they are helpful because they get absorbed through the skin and deaden the nerves that are causing the pain without damaging the other fibers which are controlling other sensations. And they are prescribed drugs, no quackery. And I think it is a great question, and patients should be treated, but I prefer pharmacotherapy because unless it is too localized, general attack on the pain can be best achieved by excellent drugs. And I use them, and there is good success. Gabapentin is my favorite. There was a drug called Pamelor, nortriptyline, which was discovered in 1945 for depression. Turned out to be a great pain medication. Many of my patients get relief, including migraine. A new drug, not new, but relatively new drug, is called pregabalin. It's called Lyrica, very powerful drug. And you can treat patients with failure with gabapentin, and they get better. So success rate is variable, but patients' comfort improves, and only small number of patients fail.
Gabapentin, that's one that I've heard from people also. When the milligrams that they take varies from like 300 to 3,800. I'm picking a number that I'm not qualified to give, but I've heard numbers that I feel were in that range. Is that kind of what it might be?
You are referring to gabapentin.
Yes.
Yeah. You never use the drug high. You start small. I typically give them 100 milligrams 3 times a day and gradually escalate by phone calls to the patient. Say, doc, I'm 25% better. Okay, make it 200 3 times a day. I go only up to 2,400 milligrams. People use very high dose, but after 25, 26, 24, 28 milligrams, 100 milligrams, any more drug that you take goes in your caca. It doesn't get absorbed. So what's the use? It's a waste of money. It's time. If they're not responding to 2,400, then use the next drug. It is between patient and the doctor and titration. That's why you don't have to come to doctor's office for that. Once you're established, make phone calls. Doc, this is going on. Okay, we'll change the medication or increase it or alter the time period. So you're right. It has to be tailored to the symptom of the patient. You don't jump into big dose and cause toxicity and they will never take it.
It's the same thing again, where the patient has to pay attention to the results with what they take. And they kind of have to say, I think I need more, or I'm doing okay with this, because you can't go into anybody's body. That somebody has to tell you.
That's my duty. I tell them that nothing may happen if you take 300. So call me in a week. I will increase and tighten you. I go up to 1,800, 2,400. Many patients get better. So patient education is the most important thing in our business. If you don't educate him, you will be in trouble and he will be in trouble.
Right.
And it will be a message. You're not being a physician then. So education is lifelong business.
Right. It definitely is. But, there are some patients, I have to say, too, that are not compliant. So that must be very frustrating on your part because you're, vested in that, too. But I'm just, the one question I just still have, is there any way, and I guess which type, is to prevent neuropathy?
Absolutely. Preventing neuropathy is the most important part in certain types. Hereditary, you cannot do anything.
Right.
Now, if you have cancer and getting chemotherapy, you can't do anything. But alcohol, toxic neuropathy. You have to educate the patient that alcohol is dangerous. A glass of wine every evening is good, but not 3 glasses of wine. They said, oh, doc, I just drink on the weekend. Binge drinking is bad. So that education is important. And the direct toxic effect of alcohol is well known, but also alcohol causes problems with vitamin absorption because it causes gastritis. Vitamin intake, poor nutrition, vegetarians, and I'm an Indian. I grew up in vegetarian society. A lot of deficiencies, B12, folate. So yes, there is education where you need to specify that while you cannot cure the disease, you can prevent it by avoiding drugs, toxins, alcohol. All those things are detrimental. For example, There is also heavy metal toxicity.
Dr. Murthy, we actually have to take a break. I only hope you will come back on our show. I feel like there's so much more we could learn and help our residents, our older residents, and just everybody who's listening and watching Project Independence in You. I want to thank you. Dr. Murthy is the Vice Chairperson of Neurology at Northwell. Again, thank you so much